quality check here. So very important to get a history on these types of patients so that you know what you're dealing with, okay? Especially when you get questionable results as far as your like ejection fractions and things like that. I wanted to show you what we're talking about though with this thing about perfusion and wash in and wash out with thallium. I think I look better in black and white, don't you? You guys have a bad week or what? Okay, let's turn the bloody thing off. Boy, that'll blind you, won't it? Okay, one of the tests that they don't do very frequently anymore is basically you, on your short axis view, you compare the distribution of thallium with stress versus rest. Okay, this is called a quantitative thallium. Okay, normally if you have normal coronary arteries, you should have a 30% washout of the thallium. So in other words, if you look at these numbers up here, okay, we have, 6, 6, 8, 10, 10, 8, 8, 10, 10, 9, 8. Okay, those represent the relative distribution of thallium on the stress. Over here, I'm going to compare that to the washout. So over here we had a 6 up at the top, and now we have a 2 over 6. So that tells me that there's a 33% washout. Okay, does that make sense? Over here we have a 3 to 8, so roughly a 50% washout. Down here we got a 4 to 10, so a 40% washout. So as long as you have 30% or more washout, that tells you that you have good circulation. That's the bottom line. Okay? Because you not only look at the blood going into the muscle, but also the potassium as it washes out. Because remember, thallium is a potassium analog. What does your heart muscle need potassium for? Okay, to contract. Remember, every time a muscle contracts, there's an exchange of sodium and potassium. Okay? And also with the heart, we also have a third element that we have to look at, the calcium, right? Calcium mainly affects the AV node, and so whenever the ventricles are contracting, we have to look at the calcium concentration, and when the calcium exchanges, that slows down the electrical conductivity so that the ventricle has time to fill with blood. However, in situations where you have too much calcium, what do you think that does to the heart? Does that make it beat faster or slower?
Faster.
Okay, faster. And that's why they give calcium channel blockers to patients that have heart disease.
Is that the same thing as a beta blocker?
No, beta blockers like propranolol, and that slows down the heart rate. Okay, but the thing is that if you understand the physiology of the heart, then you'll understand a lot more of what we're doing to see it. Okay, so this thing here, like I say, all we're doing here is we're comparing the wash in to the wash out. So this is a fairly normal study here because it's more than 40%. And that's why the printout here, this shows the stress distribution of the radiopharmaceutical. This is the rest. And so long as there's a difference of 30% all the way through here, then you're good. Have any of you guys done this? Okay. Yeah, basically, this was a test that was done with just planar imaging. basically they would do a 10-minute picture of the heart in anterior LAO and either a 70-degree LAO or a left lateral. So you get 3 different pictures of the heart in those positions. Okay. One of the other things that we are very, very concerned with, especially with cardiac imaging, is the medications that the patient's taking. In fact, we went through the PQRST, and now you're going to take a look at the SAMPLE. Remember that? From your patient care class, what is the sample used to tell you? What does the S stand for? Okay, actually it's signs and symptoms. What's the difference between a sign and a symptom?
Signs are objective and symptoms are subjective.
Okay.
Experienced by the patient.
Yeah, this is something that you would note if the patient has edema, cyanosis, ulcers on the skin. Those are the signs. Symptoms are what the patient complains of. Next thing here, the A. What do you think that stands for? Okay, allergies. Okay, because remember, some of the medications that you're going to be administering, the patients may be allergic to it. Speaking of that, M stands for, medications. And when was the last time they took it? Okay. And then what does the P stand for? Huh?
Past exams.
Okay, actually past medical history, okay, like say exams or things like that. And then what about L?
Last meal.
Okay, when did they last eat? Is that important to us? Yeah, if you're doing a thallium study and the patient has eaten something, where is your radiopharmaceutical going to go?
Stomach.
Okay, yeah, or to the GI tract. Remember that thallium will follow the distribution of muscular activity. And in fact, we used to even use it to evaluate perfusion of the leg muscles on patients that had claudication. Don't do it too much. I don't think they do it at all anymore. But anytime you need to evaluate muscle activity, that's a good test. Okay, what about E?
So, events.
Very good. Okay, so this is where the person describes why they're in the hospital now. Okay, so let's take a look at some of the medications that we need to be aware of. These are all ones that affect the cardiovascular system. So if we're really trying to get like a true resting heart image, some of these things can affect it. Well, obviously diuretics. Okay, and later on we know that patients that are in congestive heart failure will be taking diuretics. If you have hypertension, you may be taking diuretics. Kidney problems, diuretics. The anticonvulsives. Notice this hypotension, bradycardia, cardiovascular collapse. When would a patient be taking this? It's also used for anxiety. Yeah. I know that you guys probably take it every day before class here. So. Okay. This one's a little bit, this Dilantin, this is more for epileptic seizures. Okay, this is like a long-term drug. So if your patient has a history of epilepsy, you need to ask them, okay, are you taking any of these drugs? Or if you have a patient that starts having seizures in the hospital, they're probably going to be taking 1 or 2 of these drugs. Okay.
Those drugs cause hypotension or?
Yeah.
Oh,
Yeah. And again, hypotension, that's going to change all the dynamics remember the N-diastole and N-systole? They're not designed for, reducing blood pressure, other than, that's just one of the side effects. And if it does it badly, then it's an adverse side effect, right? The antidepressants, kind of the same thing. Notice orthostatic hypotension. What the heck is orthostatic hypotension?
Decreased blood pressure upon standing.
Yeah. One of the things you've probably noticed when you sit a patient up too quickly, they feel dizzy. That's orthostatic hypotension. Potentially a dangerous situation if they pass out on you and hit their head. Also notice tachycardia, EKG changes, hypertension. If you remember that you may be the person monitoring the EKG, and if you start seeing EKG changes, then normally that's an indication to stop the study, because something may be going on. So you've got to be aware if they're taking drugs. Okay. Antipsychotics, Thorazine, yay! Again, all these in Haldol and all. Okay, all of these little things here. Again, hypotension. The stimulants, amphetamines. Now, of course, we're hoping that these are prescribed drugs and not something that people took on the street. But again, I worked at County USC Medical Center, and I would say the majority of patients were on something. You don't get into the county hospital system, yeah, voluntarily. Okay. Same thing, caffeine. For some reason, people think that no-dose, and have you heard of these before? No-dose? I think now they call it, what's that one, the 6-hour energy drink? Or,
5-hour energy.
have you ever taken that?
Isn't that just B vitamins?
Yeah, it's B vitamins and I think a
I
little
don't
caffeine
think
or something. I mean, basically all this stuff is caffeine.
Coffee.
Yeah. Basically, they just put caffeine and B vitamins in there, and whether, I don't think it really does much. Yeah, I remember my students at Drew were taking it like crazy, and the stuff didn't help them. I mean, maybe you're wired, then you can't sleep, and then you've got sleep deprivation as well as, huh? Yeah, I think it's kind of the placebo effect. It's like you take those pills that make you think you're losing weight. Rather than exercising and watching your diet, you take these pills as
Strong effect.
yeah.
Caffeine also affects the Lexiscan, doesn't it?
Yes. That's a big thing. A lot of these drugs that we're looking at here are going to infect your adenosine receptor drugs. And basically, the first drugs that they came out with, I don't know, are you all familiar with how adenosine and how Lexiscan works?
Yes.
These are adrenergic receptors.
Yeah, you have these, they call them A1 and A2 receptors in your blood vessel. And when they're stimulated, okay, the A1 receptors are found on blood vessels throughout your body. So you stimulate that, and all of your blood vessels dilate. See, that was the big problem with quercetin and adenosine. Okay, they were A1 receptor stimulants, and so what would happen is, the patient would, all of your blood vessels would dilate. Lexiscan is an A2 receptor stimulant, and those are only found in the coronary arteries. So Lexiscan was supposedly the save-all of our new cardiac imaging, because theoretically it only would stimulate the coronary arteries. I haven't, to be honest with you, I haven't used it. I haven't done imaging for a few years now, so I really don't know. I mean, my daughter does it all the time at her place, and in fact there was some issues because adenosine costs about maybe $35 a dose. Lexiscan is about maybe $100 a dose. So if a doctor orders Lexiscan and you use adenosine instead and you pocket the rest, that will probably get you in a lot of trouble with, you know, whatever agency is monitoring expenses. So just FYI, don't, you know, we actually, one of the x-ray techs that I used to work with, he did that. We have the low osmolarity contrast agents, and then we had the cheap high osmolarity contrast agents. They were like $5 a bottle. The low osmolarity was like about $100 a bottle. He was pocketing the difference until they caught him. Now I don't know what he's pocketing, but he may be out of jail now, I don't know. It's 20 years ago. So, okay, so anyway, so we go over here, the cholinergics. Okay, notice it release acetylcholine from the nerve endings. Remember, what is acetylcholine?
It was the hormone for.
Is it a hormone or a neurotransmitter?
Oh, no, the neurotransmitter.
Okay, it's a neurotransmitter.
Stimulates the-
And notice it says it blocks it. Remember, it kind of deactivates cholinesterase and some of the other things. So notice it slows down the heart, increases peristalsis. There's a relationship between sympathetic and parasympathetic stimulation. Sympathetic is the fight or flight. So that basically, you know, dilate your eyes, get your heart, your blood pressure up, and your, yeah. And then the parasympathetic, that's feed and breed.
Rest and digest.
Well, yeah. They called it, well, they told me it was feed and breed. Because that's when you know.
Yeah.
Feed and breed?
Breed, yeah, like
I thought you said breed
sex.
first.
No,
Oh.
breed is in sex.
Yeah.
Yeah.
Okay, breed.
But anyway, so the thing is, notice it says it's vasodilation of all of the, your genitalia, okay? So, and some of these you're going to see, because later on in chapter 3 of Ann Steves, there's a whole section on drugs, okay? So later on we're going to come back and look at that. I have a little test for you on non-radioactive interventional drugs. So towards the end of that chapter on radiopharmaceuticals, there's a whole section that talks about the stuff that we use for in nuclear medicine. So things like adenosine, atropine. Let me just get it here for a second so that you guys can be prepared before I break my neck. On page 33 of the Ann Steves book, okay, I want to take a look at some of those things here. The ACD solution, that's an anticoagulant that we use for labeling red blood cells, especially when we use chromium-51. Dimox, you may or may not have done a brain scan with this. I mean, some places do this on patients when they have decreased brain perfusion. They give them some Dimox. Dimox releases carbon dioxide, and that causes your brain blood vessels to dilate. Here's our adenosine. Here's ascorbic acid. Yeah, Becanol, that may be used when you guys are doing gastric emptying studies. Notice that it also drops your blood pressure. So that's why I included it in that list. With all of the people that are getting that gastric bypass and lap bands and all this other stuff, you know, a lot of them are taking drugs to do things. Captopril, have you seen that one? Yeah, it's the ACE inhibitor. It lowers your blood pressure. Patients that have hypertension are taking that. You may be giving it to a patient. What would you be giving a patient captopril for?
For a renal scan?
Okay, for renal scan, and what specific pathology are you looking for? okay, they have hypertension, but this is a drug that helps us diagnose what condition of the, the reason why we do the heart scan is because we have a, stenosis of the coronary arteries. And so when you have renal artery stenosis, this is what we use that for. The three big blood vessels that are affected by, the glycerides and the cholesterol are the carotid arteries, the coronary arteries, and the renal arteries. Those are the big three. So the patient maybe if we do a study with captopril, does anybody know what we're looking for? What happens? I know we're going to be talking about this in depth when we get into the renal system, but yeah, because normally what happens is that if you give captopril and there's no change in the renogram, then that means that that's the kidney that has the renal artery stenosis. If we give captopril, the blood pressure is supposed to drop, and that's going to lower GFR. So you should see the GFR go down. The kidney's not, a normal kidney will not work as well when you give captopril, so it cuts down the function of it.
So if it's still right, then you know there's a problem.
Yeah, but if it stays the same, that tells you that there's renal artery stenosis. Later on, we'll talk about the mechanism of regulating that. Cholecystokinin, you guys have probably used that. Cimetidine. Cimetidine is also used as an antihistamine for contrast reactions, but notice that we also use it for Meckel's diverticulum. Have you guys used it at all?
I did a Meckel's, but I did use that. We use persistent paragastrin or something.
Yeah.
Anti-gas.
Yeah, pentagastrin. Yeah, they've got different things, like this one here, this kind of keeps the technesium in the gastric mucosa. And so what happens if you have gastric mucosa in the, the small and the large intestine, it'll pick it up there.
Isn't that for heartburn too?
Yeah. It's actually, Tagamet is actually an antacid. Yeah. But they also found out that it's a good antihistamine.
That's what.
So it stimulates the mucosa cells to secrete.
Well, no, what it does is it causes it to hold it in once it is. Yeah, the pentagastrin is the stuff that they use to stimulate it to make it take up more. But see, now this one here is important, dobutamine. When would you use dobutamine?
When someone has asthma.
Okay, a patient that has asthma, we cannot use adenosine or any of the Lexiscan or any of that. So this type of a test here, you're literally like putting the patient on a treadmill, pharmacologically speaking. And notice that it says, okay, so incremental dose rate over 3 minutes. Okay, you start at 15 micrograms per kilogram per minute. So that's the first phase. And then after 3 minutes, then you increase the dose. And then when you get up to about 40 micrograms per kilogram per minute, that's like at maximum. We have a thing called the Bruce protocol. You guys ever hear that, the Bruce protocol? What is it?
It's like the 6 stages of the treadmill where it goes up a certain inclination.
Okay, but we're trying to get a certain heart rate, agreed? Okay, so Ashley, how would you determine when your patient is at the proper heart rate?
Well,
Let's
they're
say,
going to be monitored, so it's 85% of whatever the heart rate is supposed to be.
okay, so how do you calculate the heart rate?
It's 220 age.
Okay, 220 minus the age, and then you multiply that times 0.85. Okay, so keep that in mind, you will see that. Okay, so you keep exercising the patient, or you try to administer dobutamine until you get to that level. Now the bad news about this one here is the patient can actually wind up getting a heart attack because you are causing what they call inotropic and isotropic changes, or chronotropic, I mean. you're causing the heart to react to a workload, okay? And then Esmolol, they told me to give nitroglycerin. Okay, then here's enalaprap, which is like captopril. Here's your Lasix. Remember that heart patients may be taking Lasix also. Okay, what about glucagon?
Increases blood sugar.
Okay, yeah, remember it releases glycogen from the liver, so it raises the blood sugar levels. It causes the mucosa not to have peristalsis. You know, you don't want to have the stomach moving when you're trying to take a picture of the Meckels. Heparin you should be aware of. The bad news with heparin is, we don't really use heparin that much anymore, you know, except when you're labeling red blood cells maybe. I don't think anybody uses Coumadin. Okay. Insulin, okay, you may or may not be using that for, you know, definitely for PET studies, but anyway, so you have an idea here. This is on page 33 and 34. You should be very, very, very familiar with these drugs. Okay, they're definitely on your board exams. Okay. Here's your pentagastrin here. That's the one that causes it to increase uptake, or actually it causes it to produce more hydrochloric acid. You know, makes it more active. Okay. Then over here, these are the methods of localization. We were complaining to the, you know, over every time they publish a new version of this book, we tell them, now you need to include this and blah, blah, blah. So they're finally including that in there. Okay. So going back to our stories over here. Again, estrogens, the main reason we're concerned about actually androgens and estrogens is because when a person gets older and they quit producing those, then we start seeing more heart disease. Okay? So we already know that oral contraceptives and blood clots and pulmonary embolus go hand in hand with each other. But remember that when a patient is having heart problems, especially cardiac arrhythmias, okay, the flow of blood in the chamber changes. And any time you have abnormal flow patterns, you're more likely to get clots forming. Okay? If the clot forms in the right side, what's going to happen? But let's say you have a patient, and if we, you know, when we have clots, they can either form in like the right atrium or right ventricle, or the left atrium and the left ventricle. What would happen if the patient had a clot that forms in the right atrium or right ventricle? Where's the problem going to be?
The lung.
Okay, yeah, they're going to get a pulmonary embolus. Okay, if it forms in the left ventricle, then where's it going to happen?
Legs.
Systemic circulation.
Okay, it's going to be in systemic circulation. And this is where you start needing to remember, where does most of the blood go? Yeah, brain, kidneys. Okay, so if you have clots that form in the left ventricle, then you know you're going to probably stroke out the patient or cause renal artery blockage. Okay, and the bottom line though on that, you know, especially in situations when you have a patient who's been coded. Code blue, you've been trying to resuscitate them, you get clots that form on the inside of the chambers. If you get the heart started, a lot of times you get clots that get pumped out. So it's not uncommon that a person may have a stroke or something as a result of that. The non-narcotic analgesic, what they call the NIAIDs. So again, hypertension. And again, like I said, if you're doing patients, you need to do a thorough drug screening on them. Because if they're taking any of these things and you don't catch it, then you're going to have one heck of an explanation. You know, like I said, the interesting one that I saw was over at one of our affiliates, where they had this poor guy on the treadmill. His heart rate wasn't changing, and then they found out that he was taking propranolol. So he was taking a beta blocker that would prevent his heart rate from going up. Do most patients know what they're taking? No, they don't. I don't even know what I'm taking. Doctor says, here, take this. Okay, take it. I have no idea what I'm taking. Oh, I do. Okay.
See people come in with lists like this long.
Well, the fun ones are the ones that bring in their bottles.
Oh, gee.
The big
And then-
bag.
Whole grocery bag.
Yeah, I'm serious, the whole
Yeah,
grocery bag.
See?
My father-in-law, I don't know how many pills he takes, but 3 times a day. The thing though is that
Part-time job.
if you don't know what they're taking, it's going to affect your study. And, okay, and this is the big thing here, you know, like I said, most of the time, we probably won't get involved with this patient history, will we? As you guys were saying, you know, the patient comes in, you throw them on the table, you start the IV, you start pumping the Lexus scan in there, and then you inject the radiopharmaceutical and you scan. So you really don't communicate with the patient very much, do you?
Not this.
Huh?
You got the history.
How in-depth is your history? I mean, I know because I've seen most of the histories that these people ask. And, I mean, this is something, yeah, the doctor should probably have a good history, but I don't think there's very many doctors that do their job anymore. You know, I think it's hit and run type of medicine, okay? But like this thing here, if you have any of these things, remember that a lot of this high blood pressure and cardiovascular disease is hereditary. So if your mom and dad died of a heart attack, don't make any long-term plans, man. You're probably, at least you'll have an idea of when you're going to die, but that's about it. So, any history of angina pectoris? Everyone knows what that is, correct? Huh? Okay, that's chest pain. Usually chest pain that you get on exertion. Okay? You have a history of acute myocardial infarction. What is the possibility of you surviving a heart attack? First time you have a heart attack, what are your odds of surviving?
To the hospital.
To get to the hospital?
80%.
50.
Oh, you guys are too generous.
50.
Huh?
50.
You're close. It's actually, you have up to about a 40% chance of not making it. But if you have subsequent heart attacks, goes down to 50-50. So the more you have, the worse it is for you, in other words. Okay, so hypertension, cerebral vascular accidents, any of these are bad. Okay. The other thing is these acquired behaviors. These are things that you actually can do something about, maybe. Your diet. Why would high sodium be a problem for you?
Draws in water, increases blood pressure.
Okay, it draws water into the blood vessels, correct?
More work heart has to do to pump against that
Yeah,
pressure.
it makes you retain water. Okay, remember sodium and potassium are two electrolytes that are always competing with each other, and one's up, the other's down. So if your sodium is high, it's going to cause the body to retain water, which means the heart has to work harder. Okay, the fatty foods, the triglycerides, and things like that. So your diet, and then if you're fat. Okay. Personality, this type of person here, the type A personality, which is this really competitive, they don't want to relax at all, they just can't stop, and then the stressful lifestyle. So these types of things, most people do something about after they have their stroke and they're sitting in their wheelchair, paralyzed.
Shouldn't smoking also be on there?
Yeah, I should put smoking on there too. Did I put it there? Oh yeah, down here. ADA. we'll talk about that. Your psychosocial history, personality, occupation. If you have a stressful job, you know, if you're, you know, de-bombing bombs, you know, taking bombs apart or something, that might be a little stressful. Domestic problems, yeah, if you're constantly fighting with your significant other or whatever, that's not good either. But these activities of daily living, okay, if you don't do enough exercise, okay, that's not good. Heart needs exercise. The smoking. Remember that I did this to one of my students who was a smoker, because they thought, well, yeah, you don't know what you're talking about. If you smoke a cigarette, what's in there that causes problems for the cardiovascular system? Besides the cancer and all that. Yeah, the nicotine. Nicotine is what we use as a vasoconstrictive agent. And so when you take nicotine in there, it causes the blood vessels to constrict. So does the heart have to pump harder, or has to pump harder? Plus you have less oxygen because the smoke and everything is replacing oxygen.
So they get like increased hematocrit and thicker blood as well.
Well, not really that so much, but down here, this is what I thought was interesting. It says, whoops.
Do they have a higher diastolic pressure?
Yeah, well, I mean, they can actually get a condition called thromboangiitis obliterans. If you constantly smoke, what happens is the blood vessels in your arms and legs continually constrict, and you wind up losing those blood vessels.
Is that why they have like cold hands?
Yeah. And if you do it often enough, then you actually lose the blood vessels. I actually have a picture. We did an angiogram on a guy that had what's called thromboangiitis obliterans. And it's because the nicotine constantly constricts the arteries to where they don't ever open up again. So you wind up losing your hands. Okay. But this thing is kind of interesting here. Notice mortality is 70% higher in patients with cardiovascular disease or coronary artery disease. Okay. So your odds, if you do have a heart attack, your odds are not very good at surviving. And this next thing here, now, this is, again, every one of your patients is a potential time bomb, so I threw this in here. So it says, you constantly have to assess them, you don't take off and leave them. One of the things that often happens is you put them on a treadmill, you exercise them, you inject the radiopharmaceutical. Woody, how long do you guys wait after you inject it before you scan?
On a
An
treadmill?
hour? Yeah, get on a treadmill.
30 minutes.
Less than an hour.
Okay. Here's the thing, usually within the first 10 minutes after they get off the treadmill is when they're going to have a heart attack. Yeah, so keep that in mind. The main thing is, you know, checking their responsiveness. One of the first things to go is their ability to communicate. So you keep saying, hey, Mr. Radke, how you doing there? You feeling okay? You warm enough? Yeah, I'm okay. Because remember, we have what they call the ADPU scale. Okay, A for alert and oriented, so they can, you know, relate things to you as to who, what, when, where, type stuff. And then if their condition starts deteriorating, then they're going to lose that ability to memorize all those things. And then eventually it's going to get to a point where they go to verbal responsiveness. You know, in other words, you have to shout at them. Then they go to painful responsiveness. Then they go to unconsciousness where they don't respond at all, and then they're dead. And that's the truth. Okay. The chest pain, as soon as they start complaining about chest pain, we better stop the study like right now and get an EKG on them, get a pulse oximeter on them, put them in a comfortable sitting position. It's easier for a person who's having cardiac problems to be in a sitting position. And the last thing, you're going to be hooking them up to an EKG, and this is where you get to shine, guys, because you can look at that EKG and determine what's going on. We are going to give you, or I'm going to give you the chapter on EKG interpretation that I I sent you, I think, about 10 chapters, okay? I'm gonna send you the rest of the chapters, but this one on EKG, we're gonna take a close look at, because it's important that you recognize some very common type of arrhythmias, like bradycardia, tachycardia, ventricular tachycardia, myocardial ischemia, infarct, bundle branch blocks, that affects, our studies. You guys need to stretch? Okay, why don't you take about a 10-minute stretch, 25 laps around the